Welcome to PGOG Pathways to Growth in Obstetrics and Gynecology for postgraduates and consultants. Today's topic is gestational trophoblastic disease with a question answer format. What is the difference between gestational trophoblastic disease and gestational trophoblastic neoplasm? Gestational trophoblastic disease is a condition where there is a trophoblastic proliferation with rise in HCG, human chorionic gonadotrophin, and it has two variants. One is a benign gestational trophoblastic disease and other is a malignant GTD. And whatever conditions come under this malignant um, form of gestational trophoblastic disease, that is gestational trophoblastic neoplasm. How do we classify this by what is the WHO classification of gestational trophoblastic disease? The WHO has introduced this histological classification in 2014 based on the histopathology examination. One category is presence of chorionic villi. All the conditions where chorionic villi are identifiable under the microscope, and that is called as hydatidiform mole or molar pregnancy. Second type is when there are no chorionic villi seen, absence of the villi. So it is a non-molar type of gestational trophoblastic disease, which is malignant trophoblastic neoplasm. So it has malignant trophoblastic neoplasms, that is non-molar type of the GTD. Whereas this hydatidiform mole is the one where the chorionic villi are identifiable under microscope. Structure of the chorionic villi, as we all know, this is the chorionic villus with the fetal vessels at the center, and there is a cytotrophoblast, and outer is the syncytial trophoblast. Now, to continue with this WHO classification, histological classification 2014, under molar, we have three variants: complete mole, partial mole, and invasive mole. Whereas under this non-molar or malignant trophoblastic tumors, we have three types. One is choriocarcinoma, second is PSTT, that is placental site trophoblastic tumor, and third is ETT, that is erythroid trophoblastic tumor. Now, as you can see here, all the red ones are considered as gestational trophoblastic neoplasms. So, invasive mole, choriocarcinoma, PSTT, and ETT are the four types of gestational trophoblastic neoplasm, whereas this complete mole and partial mole are pre-malignant conditions, or these are benign conditions with a potential to convert into malignancy. PSTT and ETT are rare. Choriocarcinoma is more common, invasive mole is more common as a type of GTT, whereas PSTT and ETT are the rare types of gestational trophoblastic neoplasms. So I hope it becomes clear to you difference between the GTD and GTN. So important concepts what we have seen till now are gestational trophoblastic disease is an umbrella term which includes all heterogeneous conditions associated with trophoblastic proliferation and associated rise in HCG. This trophoblastic proliferation and the production of HCG is increased. Gestational trophoblastic disease includes both benign and malignant conditions. Gestational trophoblastic neoplasm is a malignant GTD, gestational trophoblastic disease. Invasive mole is unique in the sense that though it is molar, it comes under the umbrella of histologically under the molar pregnancy, but it is malignant. That means it can invade. It has got a property of invasion as well as it has a property for sending the metastasis also, and that is why though it is molar, it comes under the umbrella of malignant or under the umbrella of gestational trophoblastic neoplasm. Pre-malignant or benign types of GTD are complete and partial mole. Gestational trophoblastic neoplasm is one of the rare malignancies where there is no need of histopathological examination to initiate chemotherapy. As we all know, for example, for ovarian malignancy or for any other malignancy, if we want to start chemotherapy, radiotherapy, or we want to even plan any major surgery, also radical surgery, we need to have a histopathological diagnosis. This is the malignancy. Gestational trophoblastic neoplasm is the malignancy which is an exception. There is no need of histopathological report to initiate chemotherapy for gestational trophoblastic neoplasm is a most important concept. Persistence of gestational trophoblastic disease after primary treatment with a rising HCG is enough to consider diagnose a case as GTN as per RCOG 2020 guideline also, or in other words, it is sufficient to initiate chemotherapy. This GTN can be preceded by, or GTN can follow a molar pregnancy or even a non-molar pregnancy also. Under the non-molar pregnancies, we can have abortion. Abortion can be spontaneous or induced. We can have ectopic pregnancy, or there can be a live term or preterm birth. What is the pathogenesis of molar pregnancy and why we should know the pathogenesis, or what is the use of this knowledge in our clinical practice? Complete mole has no maternal chromosome, and that is why it is called as a process is called as androgenesis. Now here, as you can see here, maternal chromosome inactivation. There is the this ovum is not containing any maternal chromosomes. It is getting fertilized by 23x sperm. There is a paternal chromosome duplication which leads to the development of 46XX. That is how the complete mole is developing. Whereas for partial mole, there is a triploidy. 23x ovum is getting fertilized by two sperms simultaneously. It is called as dispermy. Suppose both are 23 contain having 23x 23x chromosomes, it will be 69xxx with the red one showing the this is from the this is of maternal origin. So we have two sets of paternal chromosomes and one set of maternal chromosome in cases of triploidy leading to partial mole. Now, what is the practical implication? What is the clinical significance of this knowledge is we can differentiate between complete and partial mole by doing immunohistochemistry. It is called as P57 immunohistochemistry or P57 KYP2 immunohistochemistry. Now, this is a protein which expresses only in maternal component. So that as there is no maternal component in complete mole, this P57 IHC is negative in complete mole, whereas it is positive in partial mole. So that is how to differentiate between complete and partial mole. This immunohistochemistry staining is based on this fact that in complete mole there are no maternal chromosomes, whereas partial mole contains maternal chromosomes. This is a normal chorionic villus, as we have already seen the structure. And what is happening in the mole, hydatidiform mole, is there is a edematous avascular hydropic. Hydropic means fluid-filled villus. So it becomes edematous. There are no vessels. Vessels are getting degenerated or absent vessels are there, and this completely this villus becomes round in shape because it is swollen with the fluid inside. So it is edematous avascular hydropic villus, and there is trophoblastic proliferation also. So both the layers, cytotrophoblast and syncytiotrophoblast, there is a proliferation of both of these trophoblastic layers with excessive production of SCG. So this is how the villus becomes like a grape. So we can say that hydatidiform is like a grape-like villus. It becomes like a grape. What are the differences between a complete and partial mole? In complete mole, uterus is usually larger than the period of gestation, whereas in partial mole, it might be smaller as compared to the dates. Usually, the diagnosis by sonography and clinically also is molar pregnancy, whereas partial mole can be diagnosed as missed abortion so many times by ultrasonography. Ovary has thecal lutein cyst in 25% of the cases of this complete mole. As complete mole, the production of SCG is much more, whereas in with a partial mole, thecal lutein cysts are rarely seen. Embryo, amnion, fetal parts, fetal RBCs are absent with complete mole and usually present with partial mole. Gestational trophoblastic neoplasm risk is 15 to 20% with complete mole, whereas 1 to 5% with a partial mole. If we see the karyotype is 46XX usually with complete mole because of the androgenesis, and both these are of paternal origin. Chromosomes are completely of paternal origin. Whereas with partial mole, there is a triploidy. There can be 69XXX or 69XXY with a dispermy, and there are two sets of paternal and one set of maternal chromosomes. Initial SCG is greater than 1 lakh milli-international units per ml in many cases with complete mole, whereas it is usually less than 1 lakh in partial mole. Medical complications are uncommon with complete, but these are rarely seen with partial. Medical complications such as hyperemesis, early onset preeclampsia, thyrotoxicosis, infection, all these are seen whenever there is a late diagnosis of this complete mole. And now with better facilities and ultrasonography facilities, more and more cases are being diagnosed earlier as compared to the previous way of diagnosis, which was usually late in sometimes in second trimester also. But nowadays we are diagnosing vesicular mole usually in the first trimester, especially complete vesicular mole with better ultrasonography machines. And that is why medical complications are relatively uncommon. Otherwise, whenever there is a late diagnosis, it is associated with a possibility of increased risk of all these complications. I will repeat again: hyperemesis, preeclampsia, which is early onset preeclampsia, that is before 32 weeks of pregnancy, thyrotoxicosis, and infection. Venous edema is widespread with complete mole. It is focal with the partial mole. Trophoblastic or TPI is marked with complete mole on histopathological examination, whereas it is mild with partial mole. And as we have already seen, P57 IHC is negative with complete and positive with partial mole. How a patient presents? What is a common presentation of molar pregnancy? What are the ways, less common ways, and what are the rare presentations with a molar pregnancy? Most common is irregular vaginal bleeding. With a positive pregnancy test and ultrasonography, when you send a patient for ultrasonography, the report comes as suggestive of molar pregnancy. Less common, hyperemesis can be the presentation. You get a case of hyperemesis and you start investigating and you do ultrasonography, and the report shows that there is a possibility of molar pregnancy. Excessive uterine enlargement, you examine the patient and suppose say the patient's gestational age is 8 weeks and you find that the uterus is 12 weeks or 16 weeks in size, and then you do ultrasonography and what you find is a without all these symptoms, irregular vaginal bleeding, sometimes less common, you can diagnose it in this way, that uterus is greater than the period of gestation. Hyperthyroidism is a less common presentation. Early onset preeclampsia, abdominal distension can be there because of the presence of large thecal lutein cyst. That can also be a rare way, less common way of presentation. Rarely you can diagnose it when patient presents with either hemoptysis, dyspnea, paralysis, or convulsions. That is, these are rare forms, especially with the invasive mole, we can get all these. And hemoperitoneum is also rare when there is a perforation of the uterus by the invasive mole. So patient will be in hemorrhagic shock, presence of hemoperitoneum, and the picture will be mostly like a what we get it with a ectopic pregnancy. But what you find is on ultrasonography, uterus will be showing the presence of vesicular. So what are the reasons for these various presentations? There is hyperemesis. Whenever there is a rise in SCG, it leads to hyperemesis, and it is mostly because of the effect of this hormone on the vomiting center in the brain, central effect. Excessive uterine enlargement is because of the enlarged villi as well as there is a collection of blood inside the uterine cavity. Hyperthyroidism is because of the thyrotropin like effect of HCG, which leads to increase in free T4 level and fall in TSH level. Early onset preeclampsia, why it is there is excess of trophoblasts lead to increase in anti-angiogenic factors leading to endothelial damage, which forms the basis of the pathogenesis for this early onset preeclampsia. Abdominal distension because of theca lutein cyst is there, because how theca lutein cysts are formed is raised HCG leading to excessive ovarian stromal proliferation, because LH and HCG have same receptors. So stromal proliferation that leads to formation of this theca lutein cyst. Rare presentations are hemoptysis dyspnea because of the lung metastasis with an invasive mole. Seizures or paralysis can be the presentation, very rare because of the brain or spinal metastasis in a molar pregnancy whenever there will be a invasive mole. How do you diagnose molar pregnancy? The first will be by measuring the serum beta HCG. It is excessive in complete mole, and rarely what you get is a false negative pregnancy test with a excess of beta HCG. That we have to keep in mind. And usually the serum beta HCG is normal in partial mole. Ultrasonography helps in diagnosis, but it has limitations to diagnose in early pregnancy. So what is the differential diagnosis ultrasonographically between this molar pregnancy and partial and complete molar pregnancy? For a complete mole, there can be a DD is differential diagnosis is leiomyoma with cystic degeneration or a multifetal gestation. Partial mole, the differential diagnosis is incomplete or missed abortion. And confirmation of the diagnosis will be by histopathological examination. So usually this is the way we diagnose by HCG, ultrasonography and histopathological examination for the diagnosis of molar pregnancy. And for invasive mole also we can diagnose it by the doing a transvaginal sonography to see the myometrial invasion which is taking place along with the presence of intrauterine vesicular mole. Now, how can you confirm the diagnosis if histopathology is doubtful? For a complete or partial mole, histopathological examination is doubtful. So it can be doubtful in early pregnancy. More and more early cases we are diagnosing, but sometimes the histopathology also there can be a doubt whether it is a complete mole or a partial mole with a very early pregnancy. In that case, immunohistochemistry helps. This P57 KYP2 IHC, which is expressed only in maternal genes, it will be negative in complete mole. We have already seen that, and positive in partial mole or in abortions. Now, if we want to differentiate between partial mole and abortion, then we have to go for molecular genotyping. Now, it is important. Why it is important to differentiate between this complete mole, partial mole, or abortion is the need and duration of GTN, gestational trophoblastic neoplasm surveillance will change. For a complete mole, it will be for a longer duration as compared to partial, because the risk of GTN is more with complete as compared to partial mole. And with abortion, there will not be any need for any GTN surveillance. What are the USG findings in a molar pregnancy? There is a typical snowstorm appearance with complete mole. There are anechoic spaces of different size and shapes filling the uterine cavity with no fetus or amniotic sac. Doppler will show increased myometrial vascularity with no internal flow. All these vesicles are avascular. All these villi are avascular. With a partial mole, thick multicystic placenta with fetus or fetal tissue will be seen. And sometimes in 25% of this complete mole, we can see the large ovaries with the presence of clear fluid-filled large cyst. These are the theca lutein cyst. So sensitivity of ultrasonography is unfortunately only 40% in early pregnancy, and specificity is 70% in early for the early diagnosis. Especially early first trimester diagnosis, the sensitivity is low. Now, whether HCG is raised only with the pregnancy or GTD, that is why I have included this slide, that what are the various reasons for a rise in HCG. It is raised in a normal intrauterine pregnancy, it is raised in ectopic pregnancy also. Then all forms of gestational trophoblastic disease, which as now we all know, it includes both molar and non-molar variants. Then familiar rise is seen from 10 to 200 milli-internationals per ml in some of the women. Though it is rare, we have to keep that in mind that without any reason, some of the women have this increased SCG. They do have regular cycles and they do conceive in spite of that. Some of the malignant germ cell tumors produce SCG, and some epithelial cancers are associated with raised SCG such as bladder, breast, stomach or colorectal cancers. So we have to keep all this in mind whenever we want to diagnose a case as a case of gestational trophoblastic disease. How will you evaluate a case of molar pregnancy before intervention or before you plan treatment? Pre-operative evaluation for medical complications should include TSH to rule out hyperthyroidism, CBC for anemia because of internal uterine hemorrhage, there is more of anemia, serum electrolytes, especially when patient presents with hyperemesis, X-ray chest, and if in suspected metastasis, we have to go for CT, MRI also. LFT for Miller to as sometimes there can be liver metastasis, and KFT. What is the best modality of treatment for a molar pregnancy? Suction curettage is the best modality of treatment in complete mole, irrespective of uterine size. I have seen or I have done myself a suction evacuation of a complete mole when the size of uterus was 32 weeks. With a, especially in developing countries, we do get cases with a late detection and patient coming for the antenatal checkup itself in a late pregnancy, late second trimester, and by that time there is excessive enlargement of the uterus and excessive production of SCG with all early onset preeclampsia. All these complications we do come across because we get so many cases till date with a neglected antenatal care where patient is seeking medical care late in pregnancy. So, but whatever is the uterine size, the best modality is suction curettage. Medical method for complete mole is avoided. Why it is avoided? Because it is associated with increased risk of GTN and ARDS risk. ARDS like picture is because of embolization and dissemination of trophoblastic tissue. And there is a with medical method there is more risk of incomplete expulsion. So incomplete removal will lead to increased risk of GTN, gestational trophoblastic neoplasm. Suction curettage is done for partial mole also. It is the modality of choice even for partial mole, except when the fetus is large, which cannot be removed with the suction evacuation. This is how suction evacuation I have shown, especially this bilateral thecal utensils, and no interference is needed. What we need to understand as a concept is even if for some reason we have to do hysterectomy, such as a perforating vesicular mole with intraperitoneal hemorrhage, severe intraperitoneal hemorrhage, and I have myself have done a hysterectomy in a case when perforation was at the cornu of the uterus, which was not getting controlled with hemostatic sutures, and to save the patient's life, we had to take a decision to proceed with hysterectomy. But in these cases also, even if you find large ovaries, cystic ovaries, you don't remove the ovaries because once we remove this trophoblastic tissue, there is a spontaneous resolution of these thecal utensils is the most important concept. We are using a suction cannula. Usually Carmen's plastic cannula is used, which is of 10 to 14 millimeter in size. It is as per the size of the larger the uterus, we will need a more larger cervical dilatation and a larger cannula for the uh, fast emptying of the uterus. The more is the time required for the suction evacuation, more is the bleeding. So what is the principle is we need to empty the uterus as fast as possible. That will lead to the reduction in the intraoperative hemorrhage. What are the indications for medical method of termination? Whenever there is a partial mole with a large fetus, or if it is a twin pregnancy where one is a molar pregnancy and one is a no, pregnancy with a normal fetus, and that fetus is large fetus, then in that case termination is and we are doing termination because of the patient's choice or because of the fetal demise, whatever is the reason, and it is a large fetus with a twin pregnancy or with a partial mole, then we might have to start with a medical method of termination. Ultrasonography guided suction evacuation is recommended usually because it will ensure a complete evacuation whenever facilities are there, and it will help in avoiding perforation. Already especially with a complete mole, uterus is enlarged in size with myometrial thinning, and that leads to a increased risk for the uterine perforation intraoperatively. To avoid that, ultrasonography guided suction evacuation is safer. How will you perform suction curettage in a molar pregnancy? Will you prepare cervix before procedure? Usually, mechanical hygroscopic dilators are used, like laminaria tent are used overnight before the procedure. One night prior to the procedure, they are used to prepare the cervix for cervical dilatation. Adequate anesthesia, IV access, and blood to be kept ready are mandatory for the procedure. These are the preparations which are necessary. Ultrasonographic guidance helps to prevent perforation as well as to ensure the completeness of the procedure. We are using Karman's suction cannula number 10 to 14. There is a question mark about the use of oxytocin intraoperatively. We will see that in next slide. Once we remove this vesicular mole completely, thorough but gentle curettage with a sharp seams large loop curate is indicated at the end of the procedure. And we have to send that all the whatever tissue we are removing, we have to send it for histopathological examination. Now coming to this controversial uh, topic related to this suction evacuation, whether we should use oxytocin during procedure or during evacuation of a molar pregnancy. Now, excessive vaginal bleeding is always a risk, and it is more with molar pregnancy during evacuation. Sometimes patients do present with excessive bleeding, and we have to do the procedure in emergency. Or when we start evacuation, sometimes patient can start having a brisk bleeding. So this is a real risk during evacuation, as well as there is a risk of embolization or dissemination of the trophoblastic tissue through the venous system, leading to ARDS like complication. Patient can have severe dyspnea and hypoxia, or this will increase, this dissemination will increase the risk of metastasis also. These are the two facts we have to keep in mind. On one hand, excessive bleeding; on the other hand, risk of dissemination. And dissemination leading to embolization and metastasis. This risk is more with oxytocin use. Dissemination and embolization risk increases with use of any oxytocic, such as oxytocin, misoprostol, or ergometrin. So, for this reason, RCOG 2020 guidelines says that oxytocin use is not recommended before completion of the procedure, and we have to use the oxytocin drip SOS if necessary, if the breast bleeding starts. Till the time bleeding is not excessive, we don't use oxytocin as per RCOG 2020. On the other hand, if you read the textbook of Williams and Novak's, what they are recommending is to routinely use oxytocin infusion during evacuation by adding 20 units to 1000 ml of ringer lactate or normal saline. We have to keep that drip running whenever we are doing evacuation so that the risk of this intraoperative hemorrhage is taken care of. So that is how there is a difference in the opinion, and for whenever there is a difference in the opinion in guideline, it is better to have our departmental guideline, or wherever at any hospital we are working, we should have SOPs so that we know the that what is the practice which is expected, and there is a common practice which is used by all the clinicians at that setup. Whether you will give anti-D prophylaxis after removal of a molar pregnancy, and a favorite question of the examiner, especially in practical examination, will be, why do you want to give it in complete mole when there is no fetal tissue? Now the answer is, here be careful about your while you answer. You have to provide the reasoning also. So answer is yes, anti-D prophylaxis is indicated in every type of molar pregnancy. Partial mole, there is no doubt. There are fetal RBCs which are containing Rh positive antigen, and that is why we need to give with a partial mole. There is no doubt about that. Whenever there is a Rh negative mother, possibility of Rh positive baby with a positive RBCs is there, so we need to give anti-D prophylaxis in partial mole. About complete mole, in complete mole also it should be given whenever there is a suspected complete mole. Then also we should be giving it immediately after the evacuation for practical reasons, because possibility of partial mole is not ruled out till we get the histopathology report. This is the practical reason, that unless we get a histopathology which says that there is no presence of fetal tissue, we can't 100% be sure that it is a case of complete mole. And in doubtful cases, we have to wait for IHC report, P57 IHC also, to differentiate between a complete and partial mole. And rarely, anti-D is expressed in complete mole also. There are rare cases where it has been seen that anti-D is expressed even in complete mole. And these are the reasons why we should be giving anti-D prophylaxis in all cases of molar pregnancy, whether it is a partial mole, complete mole, or invasive mole. What will you do if there is a persistence of bleeding, or there is a severe intraoperative hemorrhage when you are doing a suction curettage intraoperatively, or after suction curettage patient starts bleeding profusely? What will you do? So if there is a persistent heavy hemorrhage with hemodynamic instability and you do ultrasonography, it suggests there is still retained tissue is there, it will be an indication to do immediate repeat curettage with running oxytocin drip. Persistent bleeding, we can also use other oxytocics such as carboprost, that is 15 methyl analog of prostaglandin F2 alpha, methyl ergometrin, or misoprostol. Which if facilities are available, we should be starting the procedure and or the preparation to and proceed with balloon tamponade also, where with the compression the bleeding will minimize. Or even some uterine artery embolization, there are case reports where it has been used, so that the patients is stabilized by the time we give blood transfusions. That is the advantage of the uterine artery embolization in this case. Rarely we have to go for hysterectomy in refractory cases. Now, as a routine, whether second evacuation to be done. Now, I was doing post graduation, say 30 years back, that time doing a second evacuation was a common practice. That means you do the suction evacuation, and after say a week or two, you repeat the evacuation and remove whatever is remaining, with the thought that with second evacuation, the need of chemotherapy is reduced. Now, at present, the role of this second evacuation is doubtful because we have better facilities. We can go for beta SCG follow-up facilities are there, and that is why the need for this second evacuation is not there in modern obstetrics, and that is why there is a question mark. It will be as per the facilities available, to be frank. Wherever patient is compliant, facilities are available, then we there is no need to go for second evacuation. How will you follow a patient after molar pregnancy? Most important clinical question. Or as a gynecologist, we should be thorough about this. So we do serum beta HCG within 48 hours of evacuation. This is considered as a baseline level. Then we repeat it every 1 to 2 weeks till it becomes undetectable. Once it becomes undetectable, once it is negative, then we do month on monthly basis for another 6 months. So this is the total duration of SCG. Initially 1 to 2 weeks till it is negative, then monthly for after it is negative, then for 6 months. So it will depend on when it becomes negative. After how many weeks it becomes negative, and then after that for another 6 months on monthly basis. If there is a persistent plateau or rise in HCG, then we consider it as a case of gestational trophoblastic neoplasm. If it is negative within 56 days of evacuation, then we can do the surveillance for 6 months from the day of evacuation rather than from the date of when it is coming negative. That is RCOG guideline. OC pills, DMPA injections or progestin implants can be used as contraception. IUCDs should not be given as contraceptive because risk of perforation will always be there, especially with the invasive mole. Pregnancy can be advised, a patient can be advised to go try for pregnancy after 6 months of negative beta HCG report. There is no rule of prophylactic methotrexate whenever facilities are adequate and patient is compliant. Its only place is whenever the patient is non-compliant. Prophylactic chemotherapy as prophylactic methotrexate. When you know that patient might not be coming for the follow-up and there is a risk that she might be lost to follow-up completely, then only there is a we can go ahead with a prophylactic methotrexate administration. Now, this is another clinical issue. Should we send whatever products of conception we get? Should we send all these POCs for histopathological examination in all cases of abortion, whether it is a spontaneous abortion, medical abortion, or surgical abortion? Should we send products of conception for histopathology to rule out gestational trophoblastic disease? Now, the recommendation is if no fetal tissue is identified, POCs are to be sent for histopathological examination. This is important. If POCs are not sent for some reason, then pregnancy test should be done 3 weeks after the abortion. If pregnancy test is positive, we have to do HCG and keep the patient with for HCG follow-up and do ultrasonography to rule out retained products of conception. Now, if there are retained products of conception on ultrasonography and you are doing evacuation, you need to send that tissue for histopathological examination again to rule out gestational trophoblastic disease. Now, how do you manage a suspected ectopic molar pregnancy? It is a very rare presentation, and I have seen a patient coming very late with a large broad ligament mass. There was adnexal mass, huge adnexal mass, and we did HCG, and surprisingly, it came in lakhs, more than 1 lakh, and that is how we pre-operatively only we could diagnose it as a case of ectopic molar pregnancy. It is a very rare presentation, but management is same as other cases of ectopic pregnancy. And whatever tissue we get, it should be sent again for histopathological examination. Now, if there is a twin pregnancy with viable pregnancy coexisting with a possible molar pregnancy, the one sac has a viable pregnancy, other sac is having a molar pregnancy. In these cases, prenatal invasive testing is to be done if there is a doubt about the diagnosis, whether it is a twin pregnancy or whether it is a partial mole. As you can see, ultrasonography picture might be sometimes confusing in very early pregnancy. And when we do the invasive testing, that means either we go with chorion villus sampling or amniocentesis as per the gestational age. The report will come normal if it is a twin pregnancy in one sac and mole in other sac. Whereas if it is a partial mole, the report will come as a triploidy. That is how invasive testing helps to differentiate between these two, whether it is a twin pregnancy with one sac having vesicular mole, other sac having a normal pregnancy, or whether it is a partial mole. Now, usual modality of treatment is termination, but for some reason or the in last few years, more pregnancies are being continued by doing a patient counseling and taking a shared decision. In that case, the chances of having a successful live birth is 50%. Live birth rate is 50%. In remaining 50%, we need to go for preterm termination because there is increased risk of hyperemesis, vaginal bleeding throughout pregnancy, early onset preeclampsia, or thyrotoxicosis. There is increase in perinatal morbidity because of this preterm termination, and there is a question mark about increased risk of GTN. Evidence at present is inadequate, at cases are less and there is no strong evidence, but still there is a slight increased risk of gestational trophoblastic neoplasm when pregnancy is not terminated. With continued pregnancy, close monitoring for preeclampsia and maternal perinatal complications is mandatory, and placenta should be sent for histopathological examination. And this patient needs to be followed as all the other cases for the whether it proceeds with the gestational trophoblastic neoplasm with the regular HCG follow. Now, when will you suspect GTN after a molar or non-molar pregnancy? Now, molar pregnancy under the beta HCG follow-up, it is very easy. Anytime there is a rise in HCG or there is a persistence plateau is there, persistent plateau, then it is suggestive of GTN. A gradual fall is suggestive of a normal fall with no risk of GTN. Persistent or irregular vaginal bleeding for greater than 8 weeks of, after any pregnancy event, that is the most common presentation of GTN. Remember that any patient who is coming with irregular vaginal bleeding, say after abortion or after ectopic pregnancy or after a delivery also, then we need to keep GT, gestational trophoblastic neoplasm, as one of the differential diagnosis is the most important concept for all of us gynecologists to use in clinical practice. Rarely dyspnea, hemoptysis, seizures, or paralysis. These events can be seen after a pregnancy, and these that then we in this with this also we have to suspect. I have seen a patient who was admitted in ICU, medicine ICU, and we got a call that patient is having post-delivery paralysis, and in that case, it was a post-delivery patient was around 2 to 3 months after delivery, and pregnancy test was done, which was positive. HCG was done, which was greater than 1 lakh. Chemotherapy was started, and you won't believe, after 2 cycles of chemotherapy, patient started walking. So that is the importance of our this high clinical suspicion to be kept in mind here, to keep GTN in our mind, because it is highly treatable, manageable malignancy. So, but if we miss the diagnosis, most of the cases will go for mortality also if you miss the diagnosis. And that is why it is very important to remember that though these are rare presentations, we always should keep the possibility of GTN in our mind in whenever we see a patient. It is not immediately after delivery, so many times it can be months after delivery, but still we have to keep that possibility in mind. Sometimes patient presents with vaginal nodule after a pregnancy event, which looks like a bluish blackish nodule over the vaginal wall, and then in that case also we have to keep the possibility of GTN in mind, because of lung metastasis and vaginal metastasis, these are the common sites of metastasis. Delayed detection after non-molar pregnancy is the most important bad prognostic factor associated with poor prognosis. This is very important to understand. So, dyspnea hemostasis will be by lung metastasis, paralysis or convulsions, paralysis with spinal and convulsions with brain metastasis, or patient can present most commonly with vaginal bleeding, and sometimes we can see only a vaginal nodule as the presentation of the patient. We should have a high our level of suspicion. We should have a low threshold to consider GTN as a possibility whenever we get all these rare types of presentations also. Common is persistent irregular vaginal bleeding after any pregnancy event. Should biopsy of vaginal nodule be taken for confirmation of a diagnosis in a suspected case of GTN? Patient is coming to you and you find there is a blue nodule. Why not take a biopsy and confirm the diagnosis? Is the usually asked question even in practical examination also. So it should never be taken. In bold, I have given this specially. It can lead to life-threatening severe hemorrhage if you try to take a biopsy from this blue nodule. As obstetricians, we are always taught throughout our residency that per vaginal examination, intrapartum per vaginal examination should never be done unless you rule out placenta previa. It is as important a concept as that if you see a blue nodule over the vagina, you should never proceed with the biopsy. There is no need of histopathological diagnosis to start chemotherapy in GTN. That is the one reason why. Because you try taking a biopsy, it is so vascular that patient can have life-threatening severe hemorrhage. So this slide, I hope that all of you remember throughout your life, and you should, no one of you will attempt to take a biopsy from a vaginal nodule. Which patients need a close follow-up for GTN? Molar pregnancy, twin with a molar pregnancy in one sac, cases of abortion where histopathology is suggestive of a doubtful diagnosis of early molar pregnancy, and atypical PSN. PSN is placental site nodule. We will see what is this in the next slide. Now, if we see all the cases of GTN, 50% are preceded by molar pregnancy where the prognosis is better because patient is already under a careful follow-up. Whereas 25% are after a miscarriage or ectopic, or remaining 25% are after a term or preterm delivery where there is a possibility of delay in the diagnosis leading to the, and because of which there can be a poor prognosis as compared to the one which are preceded by molar pregnancy. So what is this PSN or placental site nodule? It was even somewhat a new information for me also. PSN, placental site nodule, is a benign condition. It is thought to be because of incomplete involution of placental site. Usually it remains asymptomatic and it comes as a surprise histopathological diagnosis when we send the specimen of hysterectomy or of a curettage. Rarely it might lead to abnormal uterine bleeding. Now, whenever this PSN has no cellular atypia, it is absolutely a benign condition. But if it is associated with cellular atypia, we call it as atypical placental site nodule. Atypical placental site nodule needs follow-up for development of GTN in future. This we have to remember. And secondly, the PSN needs to be differentiated from erythroid the trophoblastic tumor on the basis of histopathological examination. How do we stage GTN? Very easy to remember. Confined to uterus is stage 1. Pelvic spread is stage 2. Lung metastasis stage 3. Other metastasis stage 4. Now, this is somewhat tricky to remember. This GTN FIGO scoring system is prognostic scoring system. We need to remember this because we use this scoring system to decide the chemotherapy, whether to proceed with a single drug chemotherapy or multi-drug chemotherapy is entirely based on this FIGO scoring system, and that is why we need to remember all these 1, 2, 3, 4, 5, 6, 7, 8. 8 parameters are there, and somehow or the other you have to remember all these, and you should always have this as a chart either in your consultation room, or it should be handy with you always. First is age, other is what was the antecedent pregnancy, third, how much was the time interval in months between the pregnancy occurrence and initiation of treatment is most important. I have given it red color because it is supposed to be the most important prognostic factor which decides the outcome in a case of this GTN. How much was the interval between pregnancy and initiation of treatment? Pre-treatment HCG, size of tumor including the size of uterus in centimeters, site of metastasis, number of metastasis, and previous failed chemotherapy, whether it was a single drug chemotherapy with a failure or whether it was a multi-drug chemotherapy with a failure. So 1, 2, 3, 4 is the score which is given. This is a mnemonic. I thought about to remember these 8 parameters for this GTN FIGO scoring system. Uh, GTN is saying that I am a highly manageable tumor by chemotherapy. Now, this I have made for myself. You can have your own way of remembering, but I found this quite useful. I is for interval between the pregnancy and treatment. First A is age, second A is antecedent pregnancy, H is for HCG. There are two M's: metastasis, site of metastasis, number of metastasis, tumor size, and chemotherapy, whether there is a history of previously failed chemotherapy with a single drug failure with a single drug chemotherapy or multi-drug chemotherapy. So this is I think this is a correct statement. Even in practice, we experience that GTN is saying I am a highly manageable tumor by chemotherapy. Now, how FIGO scoring helps to decide the treatment is score less than or equal to 6. You start single drug chemotherapy on a weekly basis with intramuscular methotrexate alternating with folinic acid, and there is usually a 100% cure rate. This is a malignancy where confidently you can say that there is 100% cure rate if score is less than or equal to 6. Greater than 6, we have to start with multi-drug, which you can remember it as EMACO regime, IV, methotrexate, etoposide, actinomycin D, cyclophosphamide, and O stands for oncovin, which is vincristine. So that is how I have remembered throughout my career EMACO regime. You can also remember like that. There are 5 drugs here given intravenously, and these are also given on weekly basis whenever the score is greater than 6. It has also a high cure rate of 94% cure rate. This chemotherapy is given till HCG is normal. Once HCG comes to normal, then it is continued for another 6 weeks. Future successful pregnancy rate is 80%. Pregnancy is advisable after 1 year of completion of chemotherapy. Now, PSTT and ETT are rare types of GTN where usually the HCG production is low, hysterectomy is required, and the treatment of these is not as per the WHO scoring. Anytime score is greater than or equal to 13 it is associated with a poor prognosis. Risk of mortality is high. These are the references. RCOG guideline 2020 has helped me a lot with Williams and Novak's textbook. Thank you so much. Our take home message is GTN awareness in non-molar pregnancy for every gynecologist. It is a must for patient survival. Thank you once again.